morning. Good morning. It's time to start the CareCast, brought to you by the Knowledge and Evaluation Research Unit at Mayo Clinic. I am Victor Montori from the Care Unit, and today we are in for a treat. We are delighted to have Isabelle Boutron today as our guest of our CareCast. Isabelle is a professor of epidemiology at the University of Paris. She heads the methods team at INSERM, which is the Epidemiology and Statistics Research Center at CRES at INSERM, which is, in my opinion, one of the top 2 or top 3 clinical epidemiology centers in the world. She is also the director of Cochrane France, and is extremely active in the areas of bias and the reporting of clinical trials. Isabelle, what a pleasure to have you. Welcome to the CareCast.
Thank you very much, Victor. I'm delighted to be here, and I'm sorry I'm from home in my son's bedroom, but I'm doing my best.
That is phenomenal. We're just so happy to have you, Isabelle. One of the ways we start this conversations is to talk about the journey. You know, how people have come to be who they are and where they are and how they're doing things, and oftentimes it is helpful for some of the younger people listening to know, you know, is this something that was designed? You know, this is the path you set up to do, or to what extent this is the result of good luck and fortune. So how does one become Isabelle Boutron?
Well, it wasn't planned at all, and it was really the results of good luck, and I think meeting the right people and being able to grab the opportunity when they occurs. So I was, normal medical student with no plan. I was willing to become a rheumatologist. I was thinking of working in a private setting. And at the end of my studies, I was, after 3 and almost 4 years of my studies, I had the opportunity to do a master. And I had the opportunity to do this master supervised by Philippe Raveau, who became after that my mentor in the field of clinical epidemiology. And I just sort of realized that's where I wanted to be and where I wanted to go. And so I sort of moved completely to clinical epidemiology, stopped everything I was doing and start again as a master student, stopped working to do a PhD student. Didn't know where I was going, but just enjoying what I was doing. And then opportunity appeared progressively, because I was enjoying what I was doing, so the work went quite well. And then some opportunity just arose, but it was just not planned at all. And I think it's just, suddenly you meet some people and you realize that's where you need to go, and just don't think and just go there. That's my advice.
Yeah. Well, it was sounds like it was particularly lucky to have had in that first master's experience the opportunity to find something that really caught your imagination, and also a phenomenal mentor like Philippe, right? I mean that was a stress. But you were not satisfied with just that. You ended up going to Oxford.
Oh yeah, so that was more planned. I had in my to-do list, I did a to-do list, and in my to-do list, I wanted to go abroad. I wanted to have the experience abroad, because it's an experience I had when I was younger, and I really enjoyed it. And so I went to Oxford after my PhD, and again, I was very lucky, because first it was Oxford, which is pretty nice.
It sounds like a really good place, yeah.
And second, and mainly, I was working with Doug Altman, Professor Doug Altman, who is Professor of Statistics, and is a phenomenal researcher who did a lot, particularly for improving the reporting of research, improving the quality of research, moving toward responsible research. So for me, it has been a fantastic experience to be in Oxford. It
Yeah,
was both a research experience and a family experience, because I was there with all my family.
you said that you had the experience of going abroad at a younger age. Where did you go?
So, well, actually, my dad did a postdoc and just sent me to his cousin because he didn't want me with him. And I've got some cousins who were in the States, in California. And I spent, 6 months when I was 11. Went to school, couldn't speak a word on English at the beginning, and just went to school. And that was fantastic experience.
Oh, phenomenal! So then you moved your family to Oxford and to and embed yourself in the English culture.
Exactly. So that was our goal. So we had some rules. You can't go back to France for 1 year, and you need to have the perfect English life. So children went to school, and we participated in all the very British life with a British Christmas, and so that was our British experience. Yeah.
No, what was the most British thing that you ended up doing?
We went to the church because there was sort of well, I think Christmas for me was very different in England than in France. So having the proper British dinner, my mom came to Oxford to do Christmas with us. So that was a phenomenal experience. And we did some punting. So we tried everything. I can tell you, all the weekends we were trying everything.
That is a wonderful adventure. Doug Oldman was quite the character, wasn't he? I saw him for the first time in Rome in 2000, and he was a scary character because he had big hair and big eyebrows. He looked like the devil, and then you approached him, and he was a sweetheart. He was like an extremely generous person.
Yeah, he was fantastic, very kind, and very busy, of course, but you always had time for you, so you could go in his office, and it was just chatting about research for 1 hour, which is, incredible. I mean, it's a fantastic experience. So you had this desk with papers all over the desk, and you discuss research, and suddenly you say, oh, I've got a very nice paper on this topic, and you just look in all the paper, all the piles, and find you a fantastic paper. So yeah, it was a fantastic experience working with him. And I also had to learn to work because it doesn't look, but there are some differences in culture between the way we communicate in France and the way you communicate in Britain. In France, we are quite direct. If you've got something to say, you just say it, which could be a bit rude in England. So I had to learn to be much more not so direct. So in Doug Altman's team, there was Sally Hopwell, and so she was my mentor. So she taught me how to write English emails, how to ask for in a good way, to communicate in a good way, and not to be so straightforward.
So Sally was your cultural your what would be your translator, your cultural translator, interpreter.
Exactly. And then she came to France, and so I became her French teacher. So how to write French.
Did she become more direct?
She became much more direct. Yeah.
Which
because
one?
we had that type of conversation where she was, talking for 5 minutes, and at the end I was just, Sally, just tell me what you want.
Which one do you prefer? Do you prefer the more direct approach, or the more what would be less direct approach that you learn?
I'm more comfortable with the most direct approach. For
so
me,
you've reverted to your French ways. Huh?
yeah, absolutely. Yeah.
Oh, that is great. You mentioned that Doug Ullman was interested in responsible research. You want to tell us a little bit more about what that means?
So it worked a lot on uh, the bad quality of research. Actually, it worked a lot, showing that we had a lot of waste in the research we were conducting, and they participated in a lot of paper related to that. And the waste arose at different levels. First, when you set up the research question, where you're going to focus on the wrong research questions. And this is because, for example, you're going to use the wrong comparator. And there is a very nice paper that Philip did on this topic, where he looked at all registered randomized control trials in the field of rheumatology, of rheumatoid arthritis. And he showed that a lot of the trials compared the new treatment to a placebo. And this is not ethical, because there is some active treatment, and you should compare the new treatment to an active treatment. And so that's an important waste in research. Another important waste in research was choosing the wrong outcome, focusing on an outcome that is not relevant for patients, not clinically important. And that's also an important waste in research. And of course, all the waste related to bad methods, not reporting the results of research, or not being transparent in reporting the results. So that was, a lot what he did. And I got really interested and really hooked by the topic.
Do you think that the reason people end up pursuing this wasteful research, is it because they don't know how to ask those questions, or is there something corrupting the way they're thinking about the questions? Is there something that is affecting their choice? For instance, we published a paper on spin where we suggested that the choice of a wrong comparator had to do with the need to show that the new one was better, and that had commercial implications and so forth. What's your take? Why does this wasteful research happen?
I think it's a mix. I think I don't think, at least I would say for academic researcher, I don't think an academic researcher, wakes up and thinking, oh, I'm going to do bad research to have a publication. I don't think so. I really think they want to do research. They want to do good research, but I think there's an educational issue where they are stuck in their topic. I mean, very often they work in fundamental research, and they want to apply it to more applied research. And so what's interesting them for their research, for their knowledge, what they really are interested in is very often surrogate markers. And they completely forget the patient. So I think there's a mix of that, and of course the need to have publication. And so the need to have publication, which is sort of, you're not very conscious of it. Well, you're conscious of it, but you probably don't realize how much it influences the way you do research. And I think the need of publications make them do a quick research and not so good research. So I think, I'm sort of but Doug Altman used to say, I'm not a black and white man, I'm a gray man. And because, it's not right or wrong. And I think it's quite a mix of different issue. And sometimes when you tell the researcher, well, this is not interested of patients, they're not aware of it. They're not aware of the fact that the research they are doing is a waste in research.
Yeah. So you're very generous.
I know.
Yeah.
I knew you would say that. No, I think it's a bit of both. I don't, but I think it's not completely. Now, when you try to convince them that it's bad research, they're not very open to the discussion. I agree with you.
I can imagine that.
To that.
Yeah, we've in our group we've discussed, where questions come from, and we try to distinguish questions that come from a knowledge gap versus a question that comes from a practice gap, and in general find it more compelling and perhaps more useful to produce research that tries to address a problem in practice than the next step in knowledge. I think, which is what one of the reasons you pointed out is this: people enamored with their fundamental research, trying to bring it to the bedside, and doing so still looking at mechanistic outcomes rather than clinical outcomes.
Exactly,
So,
exactly.
yeah, yeah.
I'm working. Sorry.
No, no, I was just going to ask you. It sounds like in your journey, there's been a lot of joy in the work that you've done and working with great people. And a member of our audience is asking us if you think that that what has guided this path of enjoying your work, has it been working with the right people or pursuing the important questions?
Oh, I think it's both. I think it's both. I mean, it's working with the right people because FIP have always got lots of different ideas, and so it's very enthusiastic and very much pushing you also. I mean, giving you opportunities. So that was working with the right people, but definitely the questions that were tackled within his team and within my team now were really, I mean, the fact that you answer important questions, that you look at research differently, that I really like the idea of trying to criticize what we are doing on a everyday basis with no questioning. And I think stepping back and saying, oh, is this a good way of doing it? And should we question what we are doing sometimes? I think it's very stimulating because suddenly you step back and you realize, oh, dear, that's all that bad. So there's a huge amount of improvement that is possible.
It takes a particular personality to enjoy that aha moment where you realize, maybe I was not thinking about it right. And then now in the discussion, all of a sudden it becomes clear to you. And when that happens, it's incredible pleasure, isn't it?
Yeah, definitely. Yeah, definitely.
If you think about a value, something that has been pushing your career forward, what do you think has been that primary value that has been pushing you forward?
So I think for me, there's two, not one, but two important things that pushes me. First, I need to enjoy what I'm doing. So for me, enjoying the work I'm doing is really important. And I think when I was practicing as a medical doctor, I was really enjoying what I was doing because I was, I loved discussing with patients and taking time with patients. At the end of my study, the times with patients were getting shorter and shorter. So I was not so much enjoying what I was doing anymore. But and then when I started doing research, I was really enjoying what I was doing, and particularly collaborating with people and moving things forward. And I think the other thing is that I need to feel that it's useful. I need to think that the work I'm doing will be useful in one way to improve something. And so I think I need to have the impression that it could have an impact. Otherwise, it doesn't. Sometimes, if you try to think too much of it, you're not sure about it. But but yeah, for me, it's something that is important. It needs a sort of a
So
meaning.
it has to be fun and it has to be useful. Now,
Yeah,
fun seems to me it's intrinsic. You sort of know when you're having fun, but useful is going to be always the judgment of someone else. How do you realize that something that you're doing is useful? Is that something that you learn from your team, or do you have other ways of getting to that conclusion?
well, it's probably wishful thinking. You think, well, possibly it could be useful, but it's. I think for me, it's important to think, well, possibly that could be useful. Yeah, um, and uh, and again, if you step back and you think about very critically, it's not very easy to say, well, is it really useful or not? You never know. I mean, it's sort of impossible to know. But at least you have the impression that it's trying to go in the good direction, I would say.
It's we torture ourselves sometimes looking at the things that we've done, and on a good day you say, yeah, this was
Yeah,
good
yeah.
work, and then maybe, but only my mother has read it, and maybe that's not so good. Uh, but then somebody discovers your paper, cites it, or brings it up at a conference, or you see it, somebody brings it up on Twitter, and I was like, oh, yeah. So sometimes the oddest papers have a second life, when somebody
That's right.
discovers
Yeah.
them and become helpful. And so those are good moments, aren't they?
Yeah. Yeah. Definitely. Yeah.
The In our unit we have these three values: patient centeredness, integrity, and generosity. And I like to ask our guests if any of these ring particularly strongly in their soul. Which of these does it for you?
So I think two are important for me. Again, too, sorry. Uh, but probably when I think of my journey at a different time point, so probably integrity was the first I was focusing on, because that's what I tackled in my research, and worked a lot on this topic, and was more having more and more understanding about it. And I think it's probably thanks to the work particularly you did and some other people did, to highlight more of the importance to be much more focused on patients, that I sort of, but I must say, because I thought back about this, and I must say it was not at the beginning. If I want to be honest, it was not at the beginning. I was not so much into at least I was not realizing how important it was. And it's more in the second step where I really realized that if you want to do good research, you can't do it from the point of view of the researcher. You need to look to move to the point of view of the patients. And if you don't do that, you won't do good research. And so I think progressively, this is how I moved to, uh, um, to patient-centered research. It's really realizing that to integrity was important, but it's not enough to do good research.
So let's do both sides of that. Let's start with the integrity bit, the integrity focus. So you've done, important work in trying to identify what makes research and research reporting, uh, how the conduct and reporting of research enhances the value and the validity of that research, which eventually translates into more impact to patients, but downstream. What's been your favorite in that work? Is there a particular part of that work focused on research and research reporting that has a special place in your heart?
Yeah, well, I think it's probably the one I did with Doug Atman during my postdoc, where we worked on spin, and so uh, because during this postdoc I came with several ideas at the beginning. First idea, oh yes, it's interesting, but think again. And then second idea, well, it's interesting, but think again. And so we had several meetings where I worked a lot for the meeting, and then I had to think again. And then I came with the idea on spin, and he said, oh, I think it's not doable, but let's do it. And so we moved that forward, and that was really, really exciting. Yeah.
And the work was exciting. What about the impact of that work?
I think it had some impact because it was presented. So it was, for me, it was I had to present it at the peer review congress, which is a very impressive congress, and I was, I think I had 10 minutes to talk, and I think I must have practiced for hours and hours for these 10 minutes. I was so stressed, but it went well, and the people were quite positive about it, and was published in JAMA, and then people reproduced and worked on the concept. So I think that was quite a nice one. Yeah.
Yeah, I was trying to remember, Isabel, when we met and in person the first time, and it was at a meeting that you had organized to try to come up with better reporting for non-pharmacologic studies. And as far as I know, I was brought in because PJ Devereux couldn't make it because
No.
Yeah,
you
he
know.
was working on blinding and that sort of thing, and I was helping out and that sort of thing. But it was the first time I was in a room with all the heroes of clinical epidemiology that you have brought in together to Paris. And I remember we had a very nice dinner at the bottom of the pyramid in the Louvre, which was a spectacular. I mean, but I think that was the first time I met you, and it was just quite impressive group of people you brought in to develop those standards. It must have been quite fun to put that together.
Yeah, so it was, well, at that time I was still a PhD student. So it was mainly organized by Philippe Raveau. But actually what we did, I think we did not know personally most of the people in the room. We just did PubMed and picked the people where, we liked the papers. And so you did a wonderful paper on blinding, and that was really, really interested. And so we were delighted to have you. And there was all these people, and quite a lot of people where after the meeting, the meeting, you've got the scientific part and then you have the social part. And Philip organized the social part in a wonderful way. And so it was really an opportunity to create links with people where you just knew the papers, but not the person. And we had very strong collaborations with a lot of the people in the room, actually. That was a great experience, yeah.
Yeah, I mean the people in that room were also quite, there's a lot of common values. There were a lot of common
Yes,
values in
absolutely.
the group,
Yeah,
right?
yeah, exactly. Yeah,
I
yeah.
think that makes it fun. Um, let's talk about the other side. When you went to the if this was Star Wars, you went to the from the dark side to the light side. When you turn from a researcher's perspective to a patient's perspective. Um, uh, what is that research like these days? What is your patient focused research like these days?
So I think I would, because I've been thinking about it, and I think you did a presentation. So I think you did a presentation at Evidence Live in Oxford.
Yes.
Philip went to this presentation and told us, you need to look at the video. And so we all looked at the video, and you were talking about burden of treatment. And that's where some people in the team really started working on the burden of treatment and move. We already had, we were already focusing more on patient-centered research, but this was really sort of a switch. And I have one of my colleagues who worked a lot on the burden of treatment, Tran Viet, and he collaborated with you. And then I had some people I know did participate in clinical research and told me their experience, and I was just appalled. They had a terrible experience and appalling experience. And so I thought, well, perhaps there is minimally medicine, but you could have also a burden for research for the patients, and you could try to improve research and reduce this burden for patients. And
Yeah.
so that's how we started by doing a systematic review on qualitative studies, and we found very interesting results.
So this is the challenge of for potential research participants to participate in clinical research, and the burden that participation would have on them, in addition to the fact that if they're participating, is probably they have a condition that is being managed, self-managed, treated. So it's incremental to the burden of
Exactly.
treatment
Exactly.
for their condition. You said that this was triggered in part by some appalling experiences. Without going into those, what have you heard, and what did you learn from the qualitative review that opened your eyes to the experience of participants to conduct the research?
So from the systematic review, you could see how stressful it could be for patients when they learn that the treatment will be randomized. So what they will get will be randomized. And I think that's for a lot of patients is extremely stressful. And with the fear to get the wrong treatment and to lose chance because you get the wrong treatment, and all the how painful it was for them, the ways the research were organized, where they were losing so much time just trying to find a way to get parking, a way to waiting in the waiting room just to see a researcher who's going to collect data. And 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 also one point that arose, and that I think is also really important, and that came back from the experience, is that when, for example, the treatment does not work and the patient withdraw from the study, it can be extremely difficult for the patients because they were in a specific environment. They knew people who were taking care of them. They had some hope of a treatment that might work. And suddenly we tell them, well, it doesn't work, bye-bye, you go back to usual care. And that can be extremely, extremely difficult. And I think most researchers don't realize what it is to be a patient. And I think there's also a wrong feeling, a wrong understanding from researchers when I discuss with my colleague. They think that, because I keep asking them, well, if you would be participating in this trial, would you come at all the visits? And they always answers, but I don't have the condition and I won't be so much willing to participate in a trial. And so, and I think that's really this wrong impression from the researcher that if you have the conditions, you're ready to do anything, and you've got time to do anything. And I think that's where we really need to train investigators and people doing trials, and for them to really go on have the other, vision of what it is to participate in a trial, and to do only trials they would be happy to participate in.
Yeah, it's an extension of some of the behaviors that patients have observed in. I mean, let me put a parenthesis here. So, this description that you've given us, is it mostly in cancer trials, or is it in a range of trials?
I think it's well, my experience was in cancer trials, but I think it could be in any trial.
Yeah, it's interesting because I've noticed that in clinical practice, some cancer doctors, some of them who participate actively in clinical trials, they implement protocols and they bring patients into studies. That when patients are not, when the treatment is not working for the patient, the first line treatment, then they try a second line treatment. Then they try the third and the fourth and the fifth and the sixth and the seventh line treatment. And the patient's well-being, the attention to their quality of life, the palliative care approaches, and other things get pushed aside because we are on this track of trying to beat the cancer. And I wonder if it's the same mindset that is coming from clinical practice to the clinical trial, or from the clinical trial to the clinical practice, where if the goal is to beat cancer, what else could be more important than that? So, we just assume that you as a participant are willing to do everything and anything. Do you have that impression?
I do, but I think it's not only related to cancer. I think it's true in all severe disease, because I had exactly the same type of experience for very rare and very severe rheumatologic disease, where, I mean, the patients are ready, they will be ready to do anything because it's a severe disease, and completely forgetting that, well, you could, you need to change your mindset. I think that's really important. And I think for me, it's a lot of training. I think it's a lot of training. I think
a lot of training in what?
I think in the training of medical students, in the training of investigators, in the training of medical doctors who want to do clinical research, we need to force them to really change of mindset. And I think it will be both good for the patients who will have a different experience, but also good for the research because they will do better research.
Yeah. It's it seems at the core level almost like a failure of empathy, or an excessive amount of empathy with future patients, because that's the other thing, is that you sometimes commit to a particularly difficult protocol because you're trying to improve the value and validity of the research you're doing now so you can benefit future patients. And maybe you have too much of a commitment to the future patient and too little of a commitment to your participants.
Yeah, yeah, yeah.
Huh. The one of the what one of the angles, of course, that you've described is the stress of being randomized to the wrong thing, and then you went to the other end, which is if at the end of the study, either because the randomly allocated intervention didn't work or the study finished, that people exit the study protocol, exit the study team, exit the study relationships that might have carried the patient over a period of time. There is you're the head of Cochrane, France. There's a Cochrane review that is often used to justify inviting patients into clinical trials that indicates that on average, patients that participate in clinical trials get better care than patients who do not participate in clinical trial. It sounds like that was a very superficial review given the discussion we're having now.
Yeah, it's a difficult question. I think they might have sort of I mean, they have more follow-up, more visits, and so they might have sort of a more treatment and be better taken care of on some part. But it doesn't mean that their quality of life during this period will be much better, and whether the long-term effect will be much better. So I think, I mean, when we did the systematic review on qualitative study, we also had some patients highlighting the good experience they had when doing research. And very often these patients also highlighted the difficulty when the study ends, because all the context of the study, because probably the team was good and was empathic and took well care. When the study suddenly finished and they go back, that's where they had the difficulties. So it's not black and white again, but yeah, it's not. It's more. I think we can definitely do much better. I think we probably, when you just look at the number of visits, where you ask the patients to come to the hospital while it probably could be done from home, completing questionnaire, the number of questionnaire you ask them to fulfill, which is just, you know, impressive. I think all this could definitely be simplified and make the burden for patients much lower.
What is your impression about the value of having patients as co-investigators in the study process, from the design, from the identifying the question, designing those study procedures, perhaps even designing the coming off the study process and so forth? What have you had experience with that? What is your sense of it?
So I had experience with that, and it worked very well. My sense of that is, I think it's important to do it, but I don't know how to do it well, if you want. And I think there's a lot of sort of statement. There must be what we call patient and public involvement. And it's even a box to tick. For example, in the UK, to get some funding, you need to tick the box, patient and public involvement. And I think a lot of investigators just put the name of patients. We have the patients and public involvement, and that's done. And then you have some patients group that become professional of patient and public involvement. So is this the right patients to involve and to help designing the study? I don't know. Should it be, very often it's a small number of patients that is involved with a lot of physicians. So do they really have a voice? I'm not sure. Or sometimes you could have the opposite, with where a patient will have a very, very strong voice and perhaps not. I mean, I think it's important to do, but I think we need to work on how we do it. And I'm not sure having just one or two patients. I mean, in a way, it's comfortable. Oh, yes, we did involve some patients. You're comfortable. I did the right thing. But I'm not sure we really know how we should do it. And I think we definitely need to work on what is the best way to involve patients. And my feeling is that it should be a lot of patients that are involved to help constructing a study, and not a limited number of patients that might have high knowledge in methodology, but will have a specific point of view and might not represent the point of view of all the patients. And I think what we need, and probably the point of view that the patient will have in one setting might be completely different if he lives 1 hour from the hospital or if he lives 2 hours from the hospital, according to his job, according to, I mean, there's lots of, it's not one patient, it's lots of different people with a huge diversity of value of what is important for them. And I think, yeah, we need to find good ways to involve patients.
Well, I think having the angle of the burden of participation is an angle that makes adds to the richness of that involvement, because like you, I've been involved in situations where the patient's voice is brought in to tick a box, like you say, or where we're just asking for general impressions. You know, what do you think of our questionnaire? What do you think of our procedure? You know, and he just has. But I think the angle of how easy or difficult, or where do you think there will be some friction or some pain points or some, what additional care will people need as they go through this that is not in our protocol and perhaps even not paid by the study and so forth. This may become really practical questions, and your proposal that we don't have just a few patients, but we have a large number of people that represent or are similar to the patients that we are going to be enrolling seems quite interesting. I don't know the situation in France about this. As you know, I have my suspicions, but I do not know it. Is in relation to the notion of diversity and inclusion. There is I think, a very welcome development in terms of having a more diverse workforce in clinical practice, a more diverse workforce in research, and certainly a more diverse and set of participants in clinical research, so that we have greater confidence that our results apply more broadly as we come up with them. The issue of burden of participation in research seems to me will be one that will interact quite strongly with factors that contribute to the discrimination of people in general in society, but also discriminate against them in their ability to participate in care and their ability to participate in research. Have you gotten into that space, and what insights have you developed?
We didn't go in, well, we tried to explore what would be the willingness of patients in terms, for example, of organization of research. So we did sort of a survey where patients, we use protocol, industry protocols of randomized controlled trials, and we created a vignette describing the protocols and proposed to the patients different organization of, so they could sign the consent form from home or sign it at the hospital. They could come at all the visit at hospital, some at hospital, some at home, or all from home, and at the end of the study. And what we could see that there was a huge diversity. And so there's not one type of organizations that would please most of the patients. And so I think we definitely need to think of the way we do research to be much more flexible. That's my point of view. And it's it would, it's a huge change in the way people organize research, because they don't like flexibility in research. You hate it. It needs to be completely organized. And I think we can make it organized, but also allow some flexibility. And what we will lose by the flexibility, we might gain it on other aspects where patients might be more willing to stay in the study, might be more willing to participate in the study. And we showed with this vignette that if you organize the study according to the preference of patients, you have much more patients who would accept to participate, who would be happy to participate. So I think it's a big change in the way, but I think the diversity of the patients, and we need this diversity in trials, because otherwise we're going just to include always the same patients living next to the hospital in this specific setting. I think this diversity will bring a lot to the trials, and will be very useful.
If you go beyond biological diversity and you start looking at social factors, country of origin, ethnicity, cultural differences, even gender. Have you interacted with the efforts to try to improve that form of diversity as well?
Not, I must say, not so much. I think we always try to discuss it with the investigators, particularly currently, in France we're a bit behind, but currently we're fighting on age, because they tend to exclude more age patients. So we try to stop exclusion criteria that have no sense, that excluding patients, because they, again, I think it's because they are in a specific context. I mean, they imagine the trials related to their own research, and forget that it's very an applied research, and so they're going to add a huge number of exclusion criteria for the patients, and so we try to fight a little bit on that when we plan the trials.
We've gone a little bit through, the integrity and the quality of research, talked a little bit about the patient perspective and how taking that in might make clinical research better. When I was introducing you at the top of our conversation, I mentioned a number of administrative positions, and I wonder about that. In your, you seem to enjoy research quite a bit. Are taking these administrative positions a curse, a bad thing, or natural evolution, something that people should be jumping at the opportunity to do, or something you have to do because you're a team player? What's your sense about this appearance evolution towards taking positions in administration?
Well, I must say, the life when I was a PhD student and postdoc student was, the most wonderful time. I mean, if you have in the audience, if people are PhD or postdoc, just, grab it and, enjoy. Afterwards, of course, you have new responsibility. I still, you learn a lot with this responsibility, and you enjoy part of it, not all of it. I think, for example, having the responsibility of other researchers, trying to help them doing their career, supervising them is really, enjoyable. I mean, it's very, very interesting, and having the interaction with junior researchers is really interesting and rewarding. So my strategy on that was to do it the latest possible, to take all this responsibility. But now I've got no choice. I can't push them anymore. So I just have to take them. But because that's part of what you say, a team player. You need to at one point you need to do your part. But yes, my strategy was really to push it, and I was quite lucky because I was able to push it quite for a while, and not to take. And I'm not taking responsibility I don't want to do. So for some of them, unless people tells me, well, there's no choice, we need someone to do it, I would do it. But if there's some responsibility that might be rewarding in terms of title, in terms of position within the university, but I know that it will mean stopping a lot of the research I'm enjoying, I will try not to take it as much as possible. Yeah. So that's more my strategy about that.
So now that you have those the opportunity of those responsibilities, what are you doing with it? Are you doing something crazy? There's something unusual with it? Are you trying to create a different set of environments or other things? Do you have a particular mission that you're after?
It depends on the responsibility. For currently, the research team, it's still Philippe Raveau is there, so it's a bit different. Cochrane, I'm trying to find my way to understand the system, because it's a huge system, and then to try to move forward the project or ideas or way of doing that I think could be different. As for example, for Cochrane, in the context of COVID, we did a platform where we identify all randomized control trials, collect data, and put the analysis online as soon as they're done. So every week we redo the analysis and we give it to the, and that's very unusual. I mean, that's not Cochrane classical way of doing. And so we tried to push, but they were quite open, and I think, and so we tried to push, other way of doing it,
Cochrane has a relatively new area on sustainable medicine that has caught my attention, because it seems like an extension of not only doing sustainable research, in other words, research that is useful, that is not wasteful, that answer questions that matter, and do so in ways that don't waste patients' time, energy, or attention, right? So more of a kinder form of research for patients, more minimally disruptive. And are you involved in that effort at all, or has it come under your purview?
Within Cochrane? I don't think so, no.
It's a field. It's a Cochrane field on sustainable medicine.
Okay.
Yeah. So it seems like it might be a potential point of interaction with
absolutely.
with this work. Yeah. COVID has changed everything, right? It's interesting because the last time we saw each other in person, it was just right after the Notre Dame had had that fire, and everything was closed. Your office, which is right next door, had residues of the smoke come on the plants in the beautiful garden there, and you know. I remember the pictures. Thea sent me some pictures from the window, and you could see the fires, and you couldn't imagine a bigger disaster on such a jewel, architectural jewel, and such a symbol of Paris. And then COVID hit. It's like, oh, you don't think you cannot think of it worse. Oh, here's worse, right? How has the dynamic changes brought about by COVID in terms of, for instance, the ability to interact more broadly electronically, and so how has that changed the way your team is working, but also the way you're imagining the future of research to be?
So it changed completely the way we are working within the team, because we were locked down in March, and we're currently still locked down, so still working from home. And so it's only online interactions. I must say, for the team, I think it's problematic because it's very difficult. And so I'm looking forward to have a new face-to-face meeting where, I mean, the interaction is much easier. You can interrupt much easily, and you can see the face and see the body language of the people much easily. So for me, the work from home and through video is not the optimal way of doing research. It works very well for a lot of things, and you gain a lot of time, that's for sure. But there is also a lot of interaction, which is, not the interaction that happens but was not planned. And this interaction is research that happened but was not planned is really important. And it's really when you have lunch, when you take a coffee, when you go outside and discuss, and that's for me, it's really a difficulty currently for research.
Yeah, our team has been apart also since March, and we meet every morning for a few minutes to check in. And when things were relaxing a little bit, we had small group come together outside with a fire, in the
Oh,
middle,
good.
so we can have those. But I think we're all hungry for the same moments that you're
Oh,
describing,
yeah, yeah,
and be
yeah,
in the same room, and it maybe it's just more fun. Maybe it is just more of the serendipity, more of the chance discussion that come in.
yeah,
I think it affects creativity. I
yeah,
think it affects the range of ideas and the extent to which you can listen to each other without taking turns, and this
yeah,
the craziness of the personal interaction. So it's a bit sad that in addition to all the deaths and the difficulties with illness and so forth, the isolation, the separation, and the
mm,
cost this will have on people's careers as
absolutely, absolutely.
significant. Having been with your group in person, it's a wonderful chemistry that you have, and I'm sure they all miss it tremendously to be in the room with you.
Yeah, yeah, it's really a difficulty, but hopefully we'll come back a little bit with mask and
And vaccines and
vaccines.
yeah,
But
yeah, hopefully that will happen soon. Um, we're getting to the end of our time, and one of the things that I think is always interesting when we talk in talking with you, but in talking with other people like you in this series, has been to ask people, what's next? What's coming? What's the big next adventure for Isabel Bouton? What's next for you?
I don't know. I mean, more responsibilities, I think. So I need to think how I'm going to take over these responsibilities, and hopefully maintain sufficient time for research. I think currently I'm quite very much involved into Cochrane and to meta research, research on research. And so I think that's where I really want to continue investing, particularly in meta research, and continue this self criticism. But what I like in meta research is that you criticize what is being done, but you criticize also what you're doing yourself. Otherwise, it's a bit too easy. So I think that's for me. It's what I'm going to plan doing, and my goal is really to try to still have time to collaborate on research projects, to work with people like you and internationally, and to continue enjoying really the research we're doing. That's my goal.
Yeah, well, if life is teaching us anything, is that you have to leave a little bit of room for that surprise opportunity that comes up, because sometimes they come with a lot of fun, and
Yeah.
yeah, and that's I am glad, very glad that you found the paper in PubMed that led you to invite me that first time to Paris.
It was
I
great to have you. Yeah.
I'm very glad that Philippe brought that video and help us come together to work with thee, for instance, on the burden of treatment questionnaire, all that work, and to work with you on research reporting and minimally disruptive research. And the collaboration between our group has been very good and a lot of
Hmm.
fun.
Yeah.
With I
Yeah.
think
Definitely.
yeah, the hallmark of working with you, and I'm so happy that someone with your commitment to integrity research and collaborative research and fun, helpful, useful research is in positions of leadership and in a capacity to shape how the next generations of researchers are going to move us forward. So Isabel, has been a wonderful pleasure chatting with you today, helping others learn what I know of you and to hear from you how you see the world, which is absolutely wonderful. Thank you very much for coming to the CareCast.
Well, thank you so much for this invitation. It's been a pleasure discussing with you, and hopefully we will have other collaborations soon.
Looking forward to those. And thanks everyone for joining us today. We hope to see you next week in the CareCast from the Care Unit and Mayo Clinic. Until next time, and please take care.